We're going to take on today a topic made particularly relevant by the current outbreak, which is the type of healthcare system in effect in the United States. As you very well know, for the past 3 years, I swore to myself never to take on domestic issues. But I'm making an exception today because this issue, particularly under the current circumstances, will be at the center of the political debate leading up to the November elections, and will have a major impact on its outcome. In considering this issue, we're also going to compare the US healthcare system to other existing systems around the world and see what can be learned or discovered when applied to the American realities. Now, let's start with a few facts. First, the United States is the only advanced economy in the world
Hello, Judy.
that does not offer
universal
healthcare coverage. For the past few decades, Washington has moved in fits and starts toward that goal, but has never quite achieved it. In 1965, major reforms to expand health insurance coverage led to the establishment of Medicare, which covers, as you know, the elderly and the disabled, and Medicaid to cover the low income and poor segments of the population. That expansion was extended in 2010 by the ACA, or the Affordable Care Act, or Obamacare, which made coverage accessible to the near poor, those having an income between the poverty line. The poverty line today in the United States is around $26,000 to $28,000 a year for a family of four, and for those without health insurance at all. Today, however, some 28 million Americans remain uninsured, and 44 additional million are underinsured, meaning that they spend more than 10% of their incomes on out-of-pocket healthcare expenses. This is the first fact. The second one is that such an expense would be bearable if the healthcare offered in the United States was not exceptionally expensive. Indeed, the United States spends 18% of its gross domestic product, GDP, on healthcare. The second highest percentage among countries in the Organization for Economic Cooperation and Development is in Switzerland, which spends 12%. So you see the whopping gap of 6% between the United States and the second country. The UK spends only 10%, Canada 11%. In 2017, Americans spent an average of $10,200 per person on healthcare, according to a Kaiser Family Foundation study, compared to the $5,300 spent in average by the citizens of similarly wealthy countries. Yet, despite spending almost twice as much as Australians, Canadians, Japanese, and many Europeans, Americans suffer from lower life expectancy, higher infant mortality, and a higher prevalence of heart disease, lung disease, and sexually transmitted infections. While it is true that some Americans have better access to advanced technologies and drugs than most Canadians and Europeans, that in certain fields, such as cancer diagnosis and treatment, the US offers unsurpassed care, and that on average, Americans experience shorter wait times for certain specialty services, such as orthopedic surgery, than in Europe. The fact remains that when it comes to healthcare, Americans pay more and get less. The third fact is that the United States healthcare system is not that the US healthcare system does so little for health, but that it does so much harm to the economy. Yes, the healthcare industry creates employment. It does pay the salaries of providers and boosts the profits and dividends of shareholders. All those expenses are an income for someone. But the resources swallowed up by that industry could be used to improving education, investing in research and development, and repairing roads, bridges, airports, and other strategical infrastructure. The high cost of healthcare in this country is all the more important that the US is the only country, again, among the rich countries in the world, in which employers are responsible for the healthcare insurance, for the health insurance of their employees. Companies with 50 employees or more must offer health insurance. In 2018, the average cost, annual cost of a family policy was $20,000. Now, for the employer, this is simply a labor cost like wages. So it doesn't make any difference to him whether the price of labor takes the form of wages or health insurance or other benefits for that matter. As a result, the constant rise in the cost of healthcare can be a deal breaker. In other words, the company will try to figure out whether it can do without the worker or whether it can perhaps outsource the job to companies that supply low-skilled labor. Outsourcing is growing quickly in Europe, and healthcare is increasingly expensive everywhere as well. But because healthcare costs in other countries are not borne by employers and are not tied to employment, there is no immediate link, immediate connection between rising healthcare costs on the one hand and lower wages and fewer good jobs on the other. The fourth fact is that, again, unlike other developed countries, the US does not exercise control over the prices of new drugs and procedures. And the healthcare sector, including doctors, device manufacturers, hospitals, and pharmaceutical companies have developed immense economic and political power. The unregulated healthcare system has also a profound effect on American society as a whole. The news media often focus on the more than 500,000 household bankruptcies that medical bills induce every year. But other substantial harms are less well recognized. For instance, the uninsured or the underinsured must delay very often or even forego treatment when they are ill, which contributes to a pernicious form of inequality. On average, the top quarter of American earners live 10 years longer than those in the bottom quarter. Making matters worse, the system is inefficient. Experts estimate that around 30% of the money spent on health care goes to administrative costs, which is around $1 trillion a year, out of a total of $3.5, $3.6 trillion a year spent on healthcare in this country. That amount is 3 times as high as that in other advanced economies. Why is that? Basically, first, because in a multi-payer system like in the United States, and I'll come back to that a little later, insurers offer many different policies, each policy with its own benefits, its own premium rates, and claim procedures, which forces healthcare providers to employ vast administrative staffs just to sort out the various plans, rules, and prices. Second, fraud and abuse also drive up the price of care, accounting for tens of billions of dollars unnecessarily spent every year. Third, the multiple payers lack the market power to negotiate effectively with pharmaceutical companies and healthcare providers for reasonable prices. And when one insurance plan, for instance, is able to negotiate a lower plan, then that provider can very easily adapt by simply charging other insurance plans higher prices, which leads to ridiculous cases where the exact same service or medical procedure can vary in price by more than 300%. And finally, the high number of uninsured or underinsured people in this country is driven up by the fact that among the buyers, unhealthy people obviously are much more likely to get coverage than healthy people. So as a result, the premiums reach unaffordable levels for those who need them more. And also because the insurers seek to optimize profits by trying to sell coverage only to those they consider good risks, such as relatively young and healthy people, and by avoiding the unhealthy, the disabled, and the elderly. The root of these problems is that as the United States became a prosperous and industrial society in the early 20th century, it chose to treat healthcare as a commercial product rather than as a social good, such as education. As a result, healthcare in this country remained primarily a private sector activity driven by the profit motive. Let's go back in time a little bit. The system of employer-based health insurance in effect today in this country developed during World War II. At that time, wages were largely frozen, and employers found that offering health insurance was one way to compete for scarce workers, manpower, labor. After the war, the US did not follow European countries in establishing a single-payer universal health insurance system, despite President Truman's efforts to do so. Now, what is a single-payer system? Simply put, it is a system in which a single entity, for instance, a government, is responsible for collecting the funds that pay for healthcare on behalf of the entire population. By contrast, a multi-payer system allows multiple entities, like insurance companies, to collect and pay for those services. Now, President Truman succeeded to establish the single-payer programs of Medicare and Medicaid for the groups of people that I mentioned earlier. But when it came to expand those programs to the rest of the population, he ran into very strong opposition, particularly certain interest groups and the AMA, the American Medical Association, which were trying to protect physicians, superior market power, and professional autonomy. The AMA mobilized its nationwide network of county medical societies to stir up fears that the plan would lead to, quote unquote, socialized medicine, going as far as to call the plan un-American. And opponents of universal health coverage have relied on variations of that same playbook ever since. Slowly but steadily, however, public sentiment has recently shifted. According to public opinion surveys and polls conducted between 2000 and 2019 last year, the proportion of Americans favorable to a single-payer, government-run health insurance system rose from 40% to 53%. And it is very likely that this percentage would go up after the coronavirus epidemic blows over here. The question, it seems, is no longer whether the United States would establish a single-payer system, or at the very least, a hybrid system, radically different from the one it has now, but rather how that change will take place and what kind of system it will produce. To help find answers, the US could look to two places as different as Canada and Germany. I purposely left out the UK's extremely socialized health care system, which most likely would not appeal to most Americans, not only because the higher taxes it implies. As a matter of fact, most of these models will imply higher taxes, but because of two other reasons. In England, there is a particular emphasis on the cost effectiveness of treatment, which leads the national healthcare insurance to refuse, in certain cases, refuse to cover medical treatments, including life-extending ones, which it considers too expensive relative to its outcome. That's number one. And also because it forces the insured to choose a general practitioner from a list provided by the government-run National Health Service. So the choice of the insured would be somewhat limited. Although I must point out that there is a private sector also in the UK, with more or less 10% of the UK population, which signed up to private medical healthcare. So let's first look at Canada. Canada established single-payer universal health insurance in 1968. The Canadians opted for a one-tier system built on the principle that coverage should be not only universal, not just universal, but also equal. What does that mean? It means that the system forbids private insurers from duplicating the benefits offered by the government and prohibits physicians and hospitals from serving both publicly insured patients and those with private insurance. Providers must choose to serve one group or the other. In the Canadian system, the federal government sets national standards for healthcare and funds 50% of its cost. The other half is funded by the country's 13 provinces, which run their own programs, acting as a single payer for their residents, determining payment rates to providers and negotiating with pharmaceutical companies. This arrangement vastly reduces the potential for fraud and abuse, since the single-payer system maintains uniform records of every medical transaction and closely monitors every provider's behavior. In 2018, Canada spent less than $5,000 per person on healthcare. Remember, the US is over 10,000. Administrative expenses related to insurance accounted for just 6% of the overall spending. Why? Because there is only one set of rules and procedures for filing claims. And the system is highly effective. Life expectancy in Canada is 82 years, and the infant mortality rate is 4.5 deaths per 1,000 births, better on both counts than in the United States, where life expectancy is 79 years, and the infant mortality rate is 5.8 deaths per 1,000 births. But this one-tier system does not please everybody, as a growing number of Canadians disagree with the system on the ground that it is in clear contradiction with one main democratic right, which is the right to choose. And more importantly, because under the principle of equal coverage of medical expenses, there are long and unacceptable delays for healthcare. As a result, the past couple of decades have seen a growing trend towards a two-tier healthcare system in which many privileged and affluent individuals are able to sign up for private health providers and receive faster and more efficient services than those without. Now, Germany offers a different and probably more flexible healthcare model than Canada, which evolved over a long period of time. Germany passed its first law on healthcare coverage as far back as 1884 under Chancellor Otto von Bismarck's social legislation. In 1914, it compelled all workers in selected industries earning less than a certain amount to obtain coverage. Those who earn more than that threshold were allowed to enroll or purchase private insurance. After World War II, West Germany continued that system, which was extended to East Germany after reunification. In the 1990s, this multi-payer system was turned into a hybrid system that relies on doctors in private practice for physician services and a mixture of public and private hospitals for hospital care. This system is mandatory for workers whose income does not exceed a certain amount, which is around 60,000 euros a year, more or less $65,000 a year at the present time. Beyond that threshold, this worker or employees can sign up for private insurance instead. And about 10% of Germans opted to do so in order to be able to enjoy a more comprehensive coverage, as some elective surgeries and certain medications are not covered by public insurance. The contributions are based on the worker's salary, and the employer pays half of the contribution and the employee pays the other half, which amounts to about 7% of his income. Patients can freely choose their providers. In Germany, the federal government sets the rules and negotiates with pharmaceutical companies, like in Canada, allowing Germany to keep drug prices relatively low. In 2017, Germany spent approximately $5,600 a year per person on healthcare. And here too, in Germany, life expectancy and infant mortality rates are better than in the United States. Now, a number of clear lessons for the United States emerge from these examples. But the basic question remains, should the United States continue to treat health insurance primarily as a commercial product shaped by market forces and one that everybody can be free to either acquire or do without? Or should health insurance be understood more as a social good, as I said earlier, like primary and secondary education, which would be guaranteed by the state, paid for primarily by taxation, and mandatory for everybody? Just what sort of change will be necessary is, as you very well know, the subject of current fierce debate right now, especially within the Democratic Party. One proposal has been the establishment of the so-called Medicare for All system, introduced by Senators Sanders and Warren. which would incorporate many features of the Canadian and German approaches, including a single payer system with one comprehensive standard benefits package for all, free choice of providers, uniform payment rules, and procedures that would vastly reduce administrative expenses and limit fraud and abuse. The savings, according to the authors of this plan, would be great enough to pay for most Americans who are uninsured and underinsured, while still giving them a reduction in their health expenses. The major drawback would be a general tax hike, as some payroll income and wealthy taxes would have to increase. And more controversially, it would imply also the disappearance of most forms of private health insurance. That would make Medicare for all, or a plan which is similar to it, run into high opposition and be unpopular with different segments of the population. With people who are currently insured, for instance, and who worry that their benefits under this plan would be reduced. With physicians, nurses, and hospitals, which obviously would see such a plan as a threat to their income. With the public in general, who would resist higher taxes, and with insurance companies, pharmaceutical firms, and powerful interest groups like the AMA and the American Hospital Association, which would lobby very hard against the shift into a genuine universal coverage. Then perhaps a more practical approach would be to create a hybrid public-private system that, while allowing for multiple insurers, would create a uniform system of payments and electronic records to help control waste and fraud. In such a system, the government would negotiate prices and would set fees for medical services. A little bit like what the publicly funded National Health Service, the NHS, does in the UK. Such a system would also let insurers collectively bargain with major pharmaceutical companies for reasonable drug prices. This approach might be a long process, but would not require the abolition of private insurance, thus sidestepping one of the most politically problematic aspects of Medicare for all. Well, as you can see from this short presentation, which I tried to make as simple and as clear as possible, the US does not need some fantastic socialist utopia in which the state would take over the healthcare system industry, but rather a better monitoring and regulation system of the current healthcare program. As it is obvious today that the huge disparities in healthcare between the United States and the rest of the developed world has increasingly been evident. And let's not forget that while healthcare might be primarily a domestic issue. It also, the system today in play in the United States is also shedding a very unflattering light on the social, political, and economic model, American model, that the US presents to the rest of the world. So even though it does not have immediate foreign policy implication, it explains a certain number of things about the United States, which other countries denounce and have been denouncing for several decades, particularly the disparities in a number of areas which have a very serious impact on the healthcare and on, generally speaking, on the well-being of Americans as a society. So this is where we stand today on healthcare. And again, this was the exception to the rule that I made today to treat a domestic issue. But with the coronavirus and this subject has been made even more topical and will be, again, among the primary subjects which will come into discussion in the months leading up to the presidential elections. Now, I open the floor to questions. And again, I remind you that it's open season on anything. If you have any type of questions, not necessarily connected or related to healthcare and related to other matters around the world, by all means, please ask. I open the floor now to your questions, if there are any.
There are questions and comments in the chat.
I don't see the questions. I just see names, but I don't see the Michelle? Hello? Michelle?
Yeah, Pierre,
Yeah.
if you scroll down,
Yes. Invite or what?
no, go to the group, go to the chat.
Yes.
You hit manage participants. If you hit that button, you'll see that all the questions are there on the side.
Oh, okay. All right. Thanks.
You might want to start down, starting at 10:59. Larry, I think that's our first question.
The first question.
I think it's Larry.
Oh, Larry, you're right. Okay.
Yep.
Thank you.
Okay.
Larry, since the question is, since you said that employers consider healthcare costs as part of wages, what are the chances that wages will rise under a government-run plan to compensate for the higher taxes needed to pay for the plan? Well, Larry, wages do rise under a government-run plan if you look, to compensate for higher taxes, if you look again at Canada and other countries like France, like the UK, it's not so much, the wages will rise, not so much in connection to the higher taxes that you'll be paying into it, but will rise based on how the economy is doing and how the company is doing. If they make more profits and it's a profitable company, the workers will get compensated more while paying the same taxes. There is no connection, again, between higher taxes and higher wages. The wages will get higher if the company is doing better. Mark, the devil is in the details. Canada, 5,000 US 10,000, Germany 5,600. What are the tax rates in those countries? Obviously, the AMA is profit-oriented. So much was Hippocratic oath. The taxes in Germany and Canada, I believe, are a little higher than in the United States. That being said, the tax rates are higher, definitely in Canada and Germany. But in those countries and other countries, which I did not mention, I took only 2 examples because otherwise we'll never finish, but there is also the European Union in general, and the Australians, the Japanese have different plans. The tax rates are higher in those countries but as you say here, you get a buck for your money. In other words, the healthcare is basically free, and that's a huge advantage. Education is basically free, including higher education in those countries. So you compensate somewhere between what you might save by paying smaller amounts of tax, but what you might get in exchange. So to the citizens of those countries, it is worth it. Now, I agree with you that in this country, imposing such a system would definitely go against everything America was built on, which is basically doing well for yourself, and if you do well for yourself and you can afford it, then you'll be able to pay your own share to get health insurance coverage or to send your kids to school. This sort of mentality of basically doing it by yourself, which is the American dream, is very different from how Europe was built up, where a larger government and a more active intervention, public intervention, in state intervention in the citizens' affair was not only included in the Constitution, but also expected by the public opinions. And they look at the United States and they consider this country, at least in this aspect, the social aspect, behind the Europeans. Now, that can be open to discussion. Is it better to have a system based mostly on the private sector, which is based on benefits mostly? Or is it better to have a system where the whole society benefits from a number of things, again, like education and health insurance, among others? That's an open debate that has been around for a while. Now, this crisis, the virus outbreak, has definitely introduced this debate in this country, where people look at the government, the federal government or local governments, more and more for help in this crisis. And they realize that the private sector maybe is not enough, that the crisis exceeded the ability of the private sector to address it. And maybe some intervention of the state is, or larger intervention of the state, because obviously there was an intervention of the federal state. A larger intervention of the state would be welcome. It remains to be seen what the frame of mind and how the Americans will look at this crisis and how this crisis could be dealt with more efficiently, and what the role of the state could be in such an instance. It's an open debate, and it will come up very short, as soon as this crisis is over, because for the time being, people are dealing with it on a daily basis, so they have not had time to reflect on it and to think about it as to what should be improved or changed or discarded in order to make health insurance in general and healthcare in particular in this country more efficient. From Peggy, what is the system in Denmark and what are tax rates to cover it? I'm not, Peggy, I'm sorry, I cannot give you an answer about the tax rates in Denmark, but as you might know, tax rates in Scandinavia in general, they are high because they cover a number of things in Scandinavia. Education, healthcare, and maternity leaves, paternity leaves, generous vacations, a number of things which come free, well, it's not free, but they are paid for by higher taxes than in this country, for sure. And the system in Denmark, I believe that without being familiar with the system in Denmark per se, I believe that it is very close to what the healthcare system is in the other EU member states. I mean, when I say EU member states, I mean the Western member states. Eastern Europe, that's a different story because for the time being, they hardly collect taxes and they the conditions in those countries are still rudimentary compared to the Western Europeans. There is a difference between Eastern and Western Europe. But for Denmark, I would say that they must be very close. I can look it up, but they must be very close to the healthcare system which exists in the rest of Scandinavia and most EU member states. Canada tax rate. Canada tax rate, it depends on the income. But I know for a fact that for doctors, for instance, to give you an example, Needless to say that being a Canadian doctor is not compared to an American doctor is much less lucrative. I know that for at least that's the way it used to be. I don't know if this is true any longer, but I know that personally, I knew a doctor in Montreal whose salary, since they are basically employed by, they work as employees, was over $250,000 a year. Well, he was paying something like 50%. So he came to the conclusion that half the year he was working for the government, and half a year he was only making 100 and maybe 150,000 for himself, but the rest was going to taxes. That's why he considered at the time, I don't know what became of him, he considered moving to the United States. But this is the exception to the rule. And also, as I mentioned earlier, not everybody is pleased with the Canadian healthcare system because of this principle of equalities. It's a sort of first come, first serve type of healthcare system. So unless it's an emergency, there are many instances in which some kind of surgery will be put off because there is a huge list of people who need, who signed up for it earlier. So it will be free, but it might take a considerable, substantial amount of time, which push some Canadians, I mentioned it, who can afford it, to sign up for private insurance, which is probably more comprehensive when it comes to some procedures which are not covered by the public insurance. And but more importantly, which are faster. From Mark, should medicine be profit-oriented or is it a human right? That's a very good question, and it depends whom you ask. Obviously, if you ask Bernie, all his speeches during his campaign emphasized the human right aspect of medicine. Now, this is very nice. That being said, probably doctors and the medical corps look at it differently, and obviously they would consider that their field, it should be profit-oriented as well. How much profit, that also is open to discussion. How much money the pharmaceutical companies should make when they charge absurd amount of money for drugs which are life-saving, that could also be and should be open for discussion. What should be the part of the state in working with pharmaceutical companies to bring down the drug prices to reasonable levels should also be open to discussion, especially when you see that the exact medication that you buy in the United States for $50 costs only 15 or 20 across the border in Canada. And then you start asking questions as to why. And why should the pharmaceutical companies have such benefits? They claim that they need the money for research and development of new drugs. But this claim is disingenuous to some extent because research and development, not at the same level, I agree, are also conducted in Europe and in other countries. And they come up with their own drugs, which are just efficient as the American drugs. So to say that all their profits go to research and development, maybe it's not quite true. Some of this money goes to their shareholders. So should that be regulated? It's also open for discussion. So you can see that the whole industry will have to go through some kind of reform, which definitely will take place, as I said earlier, because again, the trend today, and that was even before the outbreak, the trend today in the public opinion is that something, even though everybody offers different solutions, something should be done in reining in the prices of drugs and reducing maybe the benefits and profits of the healthcare industry per such, because it's getting out of hand and because the percentages of increase every year go through the roof. They are they exceed largely the cost of living every year. From Suzo 83 to everyone, I suggest viewing the film Lorenzo's Oil. It deals with the power of certain interest groups, especially the AMA. Duly noted. From Douglas, Pierre, really enjoying your presentation on healthcare. While I don't recall if you commented on this, but it is ironic that Obamacare was based on a program put together by the Heritage Foundation. You see, I didn't know that, Douglas. A major concern that I know, a think tank, isn't one of the issues, the complexity of America in terms of its sheer size and heterogeneous population. Sheer size. You know, the European Union has 530 million people. This country has only 320 million people. So the size of the country in itself, I don't think it is it would be a hurdle. Heterogeneous population, you know, so do other countries, not only the United States. Other countries in Europe or elsewhere have a very large population of people who came from somewhere else. So I don't believe that this is particular to the United States, or it's a pretext not to do anything about healthcare here. I believe that, again, it's a frame of mind and the mentality of a capitalistic system like others somewhere else, but maybe a little more oriented there towards the individual achievement and accomplishment than the good of the society, if you understand what I'm trying to say, like in Europe. It has probably historic reasons, more than the fact that the complexity of this country and its size. But I did not know that Obamacare was based on a program put together by the Heritage Foundation. I'll look it up. It must be, it's interesting. That being said, the Obamacare worked to some extent, was successful to some extent, but obviously it was flawed also on a number of issues. So it's a mixed bag of accomplishment and flaws. The question remains how the Obamacare will be implemented, if it will be fully implemented. I don't believe so, because it turns out that even under the Obamacare, which is rather complex and put a lot of emphasis, so I believe it could have been put together by the Heritage Foundation. The Obamacare put a lot of emphasis on the role of the private healthcare industry. But it has not been fully implemented because of obvious reasons, a change in administration in 2016. And it remains to be seen if it could be successful if fully implemented. But I think we won't get an answer to that question anytime soon, because the previous administration wants to roll back, as you know, the Obamacare. So it remains to be seen how this is going to play out. From Mark, does capitalism lead to advance better treatments and innovations? Private industry moves faster and more efficiently with less waste and bureaucracy than government. That's an argument. It's a valid argument. It moves faster, probably. Is it more efficient? That's where the question is. Less waste and bureaucracy. Well, in the case of healthcare that we discussed today, I have my doubts, because as I told you, if you're a provider of healthcare, private, and you have different insurance plans, private, each one with its own rates and its own plans and its own benefits packages, going through all of them, and you have different patients, obviously, with different plans. And if you have to have a huge amount of people on your staff who deal basically only with working out those claims, I don't know, I doubt that it will be more efficient that if you had a one single payer system where you won't have to go through different, which would have a uniform standard plan, without having to go through every plan and to try and figure out how to provide it and how percentage to be paid by the patient and how much will be provided by the insurance company, and having to deal on a daily basis with different insurance companies around. So I don't know if in this particular case, in this instance, private sector, private industry is more efficient than would be a state, a single payer system. That being said, capitalism lead to advance better treatments and innovations. I don't know, you know, the capitalistic system is very much in effect in other countries also that I mentioned earlier. Where they have treatments and innovations, medical innovations and innovation and treatments as well. So the United States is not the only one. Now, based here on the sheer size of the country and its wealth, it goes without saying that US is in advance. I go again to, I'm referring to medical treatment than other countries. But to say that, to imply, in other words, that other countries do not have this capitalistic system is wrong. The other countries do just in that area, just like the United States. From Phyllis, we currently have insurance companies supplementing Medicare. Is it something that would still be in place under a Medicare for all? I don't believe so. I think that under the Medicare for all, there will be no, I don't know if it, under Sanders' plan, the private insurance companies will disappear almost from one day to next, whereas under Warren's plan, it was a gradual reduction of the role of private insurance. But as it is, to answer your question, I do not believe that under a Medicare for all plan, the private insurance would play a role anymore. That being said, to go back to Europe, I want to just to let you know that the Europeans who sign up or have to sign up for private, for public state insurance can also sign up for so-called private insurance, which come in, which complement their public insurance. There are private insurances and they cover a number of areas which public insurance doesn't cover 100%. So you have that possibility in Europe as well. From Sherry to everyone, thank you for an excellent overview. Thank you. That's not to everyone, it's to me. I'm curious about the healthcare system in France, also other Western countries. Are they all variations on public? Yes, just to give you a very quick answer, yes. With universal for all and the option for purchasing additional complete, yes. Yes, yes to all your questions. Italy, France, Germany, basically Belgium, the EU member state, the Western EU member states, they all follow the same pattern. They have the same type of variation. You're right, it's not exactly the same percentages in every country, but they follow the same variation, which was, again, introduced in Europe, in Western Europe, after World War II, when Europe, in that respect, Western Europe and the United States went different ways. From Alan, you have focused on individual health coverage. Can you expand discussion to include public health system, which has historically dealt with epidemics, vaccines, etc.? Can you compare national health system in US and other developed countries? Well, that's what I tried to do in my presentation. That being said, are you referring only to epidemics? How national health system in US and other developed countries deal with the epidemics, or are you referring to the public health system in general? Because if it's in general, Alan, and I'm sorry, but that's what I tried to do in my presentation, then I guess I don't know. Yes?
Yeah.
Yes.
I'm talking about the existence of a national public health system as well as state and citywide. For example, in New York City, we have public hospitals that are administered by the city and
Yes.
private hospitals. And there are fewer public hospitals, and there's very little coordination or difficulty in coordinating the two in their efforts in combating this pandemic. At the national level, what you have is the failure of an infrastructure that would allow them to provide the necessary equipment and coordinate that. That's something I don't know whether that's the efficiency we have as
No, I understand. I understand, Alan. I understand your question now. When it comes to these epidemics in particular, now this is where the sheer size of the United States comes into play, because obviously European countries do not, except for Germany, which is considered a federal state, but obviously a much smaller federal state than the United States, where you have interventions from local governments and you have intervention from state governments. But basically, in this particular instance, you have also in Europe, in Western Europe, public hospitals and private hospitals. But the coordination, unlike in the United States, was not made at, or is not being made at the local level. It's being done at the national level. So even though it took longer in the beginning to coordinate the effort, although it took a little bit of time here too, but it took a little longer in Europe to coordinate the activities of private and public hospitals. And they also faced, like here, nobody was immune, not in Europe, not in Asia, not in the United States. So you can put them on the same footing. Nobody expected this epidemic to gain traction so fast and to spread so quickly. After a period of adjustment in Europe, the state, the government, so to speak, took over the coordinating part of healthcare in every country in Europe. Was it done any more efficiently than in the United States? From what I can see on the French news, and as far as France is concerned, obviously, I doubt it. They still do not have enough testing kits, like here. They still cannot test most of their populations, like here, even though their populations by country is much smaller than in the United States. They still not make masks as fast as needed, like here. So they run into the same issues, same problems to deal with these epidemics than the United States. So I don't believe they have been more efficient in Europe. So when you compare with what was done here, I don't see any difference, or to answer the previous question, I don't see the efficiency of the private sector and its ability for innovation, which resulted in better and more efficient results in this country than in Europe. I would say that basically Europe and the US are at the same level at this time. But yes, to answer your first question, there are public, or not question, but when you spoke, there are public hospitals and there are private hospitals in Europe as well. From this, you asked me another question. Decentralized private sector seems unable to address the pandemic, ventilators, etc. Do other countries have better healthcare infrastructure? No. Well, I answered your question in my previous answer. No. The evidence is that the Europeans haven't done any better than the US in terms of their infrastructure, because once again, they did not expect the virus to spread so fast, even though apparently, once again, this is not something which was made official, but just for your information, it seems that the first cases of coronavirus were signaled in France back in December or November of 2019. But at the time, like the United States, these first signs were not taken very seriously, since the Chinese in Wuhan in particular have not intervened before end December, early January. And even then, they downplayed the impact of the virus by saying that it wasn't such a big deal, it can be taken care of locally, and they had only a few cases of it. When they knew that this virus was serious and was spreading extremely quickly. Not only that, but the Chinese let citizens travel to other parts of China and overseas to other countries, which needless to say, made this issue much more serious. From Emily, is there healthcare coverage in China and Russia? If so, how does it work? There is healthcare coverage in China and Russia, and in those countries, it's mostly state coverage. How does it work? I cannot tell you how does it work in this particular case, because China obviously had to come up with some information about the virus, because obviously the virus comes from China. Speaking of China, actually, this morning I came across a local radio station here in New Jersey, I think in Patterson. And there was a program, I didn't know they had that. It was totally at random. I was zapping on my radio. I came across a program in English about the virus, and with a couple of correspondents, one of them in the US, the other one in Europe. I don't know where, in London, I believe. Speaking about the way the consequences, the economic consequences of the virus in Europe compared to the United States. And I found it interesting because the presentation seemed accurate and to the point. And then the coordinator of this debate, if you can call it debate, I was very surprised to find out that was based in Beijing, in China, and that the whole program was sponsored officially by Communist China. And even though the presentation was very interesting and coming from a different angle maybe, but to me, it seemed very accurate. What struck me mostly was that the total lack of responsibility coming from China, and again, this is their official program or propaganda, or call it whatever you want, even though, again, it seemed to me very impartial. Total lack of responsibility for what happened. Basically saying that the virus came, never mentioned a word about China, that came and was impacting very negatively, obviously, the economies of the United States and Europe. United States and Europe, which were guilty in the eyes of the commentator, the main commentator, of accusing China of having spread the virus, but not a word about the fact that the virus did come from Wuhan, and everybody agrees with it. So I don't know how, under these circumstances, what I found interesting is how under these circumstances, a total lack of responsibility from the Chinese, how the relations between the European Union and mostly the United States and China will develop in the future once this pandemic is over. Because in my eyes, the distrust between, and again, the Europeans, even though not as vocal as the Americans, because probably they need trade with China maybe a little more than the United States. Europe also has been denouncing this Chinese total lack of responsibility in this outbreak. So how the trade and relations, foreign relations between China and the United States on the one hand, and China and the European Union on the other hand, and Australia also needs to be mentioned, will develop once this pandemic is over. What are the implications of this mistrust with the Chinese? What implication will that have on the future foreign relations between the two leading economic powers in the world? It will be very interesting, instructive to see. What will be the consequences, number one, and how, if in any way, the relations between these three parties can be fixed and repaired in the near future. That will be a subject, obviously, that will come up also during the debate leading to the election. If debates will be held, I don't know yet how this is going to work out also. But this is one subject will be interesting to see how the different candidates will deal with when they will come up for discussion. From Alan, again, in Canada, I believe wait lists vary from province to province. How do doctors' incomes in Canada and other developed countries compared to ours? Well, Alan, I think you missed part of my, you're not there when I mentioned that. Not that the wait list varies from province to province, which is true. Ontario has its own list, Montreal, Quebec has its own list, Saskatchewan has its own list, Alberta has its own list, and so on and so forth. So the list varies from province to province. But the income of the doctors in Canada, I think, well, I don't think, I did mention that compared to other developed countries, they are lower beyond a certain threshold, beyond a certain amount. Because Canadians, again, not doctors in particular, but Canadians in general, when they make, and the high income Canadians pay up to almost 50%, I believe, in taxes a year, beyond a certain, I think $250,000. It used to be, maybe it's a little more today. Wouldn't Medicare for all take an enormous burden of American industry? And if so, why don't they lobby for it? Robert, well, I think payroll taxes would be much higher. I don't know if the burden would be off the American industry. And why don't they lobby? And why doesn't the industry lobby for it? Well, American industry, Robert, is a very general term. You have industries like even the medical industry itself, as I mentioned to you earlier. I don't think the doctors, the nurses, or the pharmaceutical companies, or the medical device manufacturers would very much be in favor of Medicare for all. Because for the private industry, it would be basically its death toll. If you have a Medicare for all system in place. So obviously they don't want to lobby for it. As for the rest of American industrial sectors, that remains to be seen what implications would have such a system on their functioning, with people having to pay higher taxes, but corporations also, and the industry will have to pay higher taxes. That's a fact to fund such a system. From Priscilla, it seems that if drug prices are cheaper in companies with socialized medicine, however, you have to factor in the higher tax rate before you make $1 for. I agree with you. That's again, it's open for debate again. Some people say, mostly in Europe again, some people say, well, more and more here also, that it's maybe they are willing to pay a little more higher taxes in order to have not a socialized medicine. You can call it, if you wish, a socialized medicine, even though that's not what it's called in the countries where this medicine is practiced. But is it worth it? That's again a debate. Is it worth getting free healthcare in exchange for a higher tax rate? And what would be the percent? Everything, again, here too, the devil is in the details. How much higher? And then you have to compare what you're getting in terms of medical insurance as opposed to what you'd have to pay for it. And it goes without saying that people who resort to doctors, people who are unhealthy or who need doctors more than others, will be probably willing to pay a little more in taxes in order to get healthcare, to be able to see a doctor whenever they need to, without worrying that either they cannot afford the drugs or they have to forego visits because they cannot make the co-payment. All this is, again, what I did today, as I'm trying to do usually, is like, you know, food for thoughts, just to open a discussion and let you make up your own mind. I'm just trying to present a few facts. From Ron, has the United Nations ever undertaken a cost-benefit study to compare different countries' health care systems, recognizing the quality and timeliness of care received? They may widely range. To my knowledge, I don't believe so. And anyway, it's not the United Nations which would do it. I believe it's the famous World Health Organization, which would undertake such a study. I think the studies that WHO have undertaken in the past referred mostly to the number of dollars and cents that people paid in different countries towards their healthcare, towards their insurance. But I don't believe that. It's very difficult also to do a cost-benefit study when you have countries where the level of medicine and the level of healthcare vary so greatly. So it's probably very difficult to undertake such a study. So again, it wouldn't be the United, it would be WHO. And I don't believe, to my knowledge, there is no such a study or published. There were studies obviously published on different healthcare systems, but to compare the quality and timeliness of care, you have to look at different countries, at various countries one by one, and do your own comparison yourself based on what every country publishes every year. And that problem, that the WHO, it seems to me they do periodically compare not the quality of healthcare, because this is very difficult to assess once again, but they compare the costs. And those are numbers that and amounts that I gave you earlier. From Mark, is this not a golden opportunity for Democrats to put forth a major change to our current healthcare system? Well, obviously, yes. Well, yes, it remains to be seen also. Again, I hate to go where you're taking me, Mark, into discussing for domestic issue, but I'm the main culprit since I took on healthcare today. So I will give you my opinion. This has been done already within the, during the primaries, obviously. Now, how much it remains to be seen also, and that we haven't done yet because the campaign per se, for all intents and purposes, has not started yet in earnest. It remains to be seen how much of Bernie's or Warren's ideas will be included in Biden's healthcare plan once he comes to present it. I don't know. The only thing that I can guess is from what Biden said earlier, is that there will be a role in his reform, healthcare reform, for the private industry, unlike Bernie's plan. But how much and how it remains to be seen. You also know that Biden, from what he said previously, is very much in favor of maybe adjusting a little bit the Obamacare. Obviously, he was there as vice president, so obviously he will take responsibility in a way for the Obamacare. But he also mentioned that he would like to bring a couple of changes or modify to some extent the Obamacare to respond to the evolution of healthcare in the United States since 2016, 2014. So it remains to be seen what Biden's new project will be. Why do we not hear anything being proposed by the Trump administration to their detriment? Why don't we hear something from the Trump administration? Because at this time, for the Republicans, why get into a debate that would not take place in the first place because everybody's busy with combating the virus? This is not the time to present new political ideas and reforms. And Trump has absolutely no interest in starting such a debate at this time. He will wait as long as possible to see what happens, and it also depends very much on the way this administration will deal with the virus, and will depend very much on when people were going to return to work, when these levels of unemployment will start going down, when the spread of the virus will take a downturn, before addressing subjects like healthcare, very sensitive subjects like healthcare in the United States. First, the Republicans would like to get some kind of feeling as to what people think in general on the way the government and the private sector intervened in this crisis, this outbreak, before addressing anything having to do with healthcare. At this time, the Republicans anyway have no interest whatsoever to start such a debate. And the Democrats, even though they would like to start such a debate, don't have a public forum to do so, because obviously we are zooming to each other. We cannot go before television and try to present whatever ideas or reforms we have in mind. So no, there will be, in my opinion, there will be no Trump presentation in that area or any other area for that matter, as long as this virus is still very much on people's minds. From Peggy, are US medical billing codes uniform in all insurance companies, or does each insurer have its own billing code? That's a very good question. I'm not an expert on...
They're uniform.
They are uniform? Thank you.
Every procedure has a special code.
Thank you very much. Well, you have your answer, not coming from me, but from an expert on that issues. From Claire, had to turn off class for past half hour, so don't answer this question if you are. I will, Claire. I'm glad that you showed up for the first half. Although life expectancy and infant mortality rates are better in Canada than today, you mean than in the US, I guess. Does that correlate with quality of life? Also, if their lifestyle is not as frenetic as ours in metropolitan areas, could that may be a major contributor to their longer lives? Well, there are a number of factors, obviously, that intervene in life expectancy. One of them is stress, obviously, and I'm not a doctor, but I assume that stress is not very helpful for life expectancy per se. Another one is your diet. Also, probably a healthier diet helps you have fewer health issues as you grow older than if you eat junk food on a daily basis. Now, is that particular to Canada? I don't know. I might vouch for Quebec because Quebec has French traditional culinary traditions. So probably to some extent in Quebec, they eat better not only than in the United States, but in the rest of Canada as well. Now, how the life expectancy rates are in Quebec compared to the rest of Canada, I don't know. But it's a fact that all this comes into play in terms of life expectancy. As for the other issue was infant mortality rates. Definitely here, the so-called socialized medicine has a beneficial impact because obviously, no matter how much money you have or how little money you have, I should say, you know that you can see a doctor during pregnancy anytime you want to, as opposed to the United States, where probably that is not the case. So a pregnancy in Europe or in Canada might be in many ways easier, medically speaking now, to follow than a pregnancy in the United States. So, and also the social net that you have in all these countries, which guarantees you some kind of healthcare, no matter what your income is. And so doesn't leave anybody out. You don't have, I don't know, 67 or 68 million people in this country uninsured or uninsured or underinsured plays a role. That is for sure. In that particular case, it does play a role. In the life expectancy, maybe a little bit less. Although, again, if you do not have any money and you do not have insurance and you do not have an emergency, you tend to forego a medical treatment because you assume that you cannot afford it. So you don't do it for something that is not an emergency. And that might impact your health in the longer run. So that's only, as for the frantic lifestyle in this country compared to Canada, that might be, yes, again, stress will definitely, any doctor will tell you that has a role in your health. From Tom, an example of American exceptionalism at its finest. The drug Danaprim, so we have an example here that Tom gives us. Thank you, Tom. Sold in several countries around the globe for as low as 5 cents a tablet, was selling in the United States for $13.50 a tablet, a 27,000% markup, until pharma boy Martin Skrell bought the company and raised the price. Yeah, I remember that scandal, to $750 a tablet, a 1.5 million percentage markup. He's in jail now, not for price gouging on a life-saving drugs, but for security fraud. This is what happens when you treat people's health as a money-making scheme and call it freedom. I thank you again, Tom, for the example. It's a perfect example. I remember this scandal, and I was personally shocked that he would go to jail for security fraud and not for this incredible move of pricing a drug, which was so important to so many people. A 1.5 million percent markup. The greed has no limits, I guess. From Alan, I read a very interesting and informative opinion piece in the New York Times of April 19. What is it about, Alan? You can text me your reply. It's about healthcare and the healthcare industry in the United States, or? So it's to all who might be interested, it's April 19. Yes, Alan.
Yes, I gave the name of the article in a later text.
Okay, all right. All right, so I'll read it, okay?
It's about the decline of our public health system in the United States over the years and the results of it. It's a very interesting opinion piece by a member of the editorial board of the Times.
Okay.
Recommended.
Thank you, Alan. From Sherry, can you be more specific about discussing how the pandemic has highlighted the flaws of our current system? For example, 1, uninsured and underinsured reticence to seek medical care for COVID-19 due to the cost, resulting in increased spread and ultimately requiring the government to step in despite our private system. 2, the loss of insurance coverage among those losing employment. 3, the massive costs required for containment, mitigations, treatment, etc., which may not be covered by our insurance programs, and again, requiring government intervention. Now, as far as uninsured and underinsured reticence to seek medical care for the virus due to the cost, we had different cases. First of all, I don't know what is the percentage of uninsured and underinsured who didn't seek medical care for the virus, because to be very fair, for the longest time, even people who were insured did not know what the virus was, because there are no information coming from the medical authorities, including from WHO, which again, only at mid-March, 2 months ago, declared the coronavirus global epidemic. So I don't know what the percentage of uninsured or underinsured people were seeking treatment, since they did not know that they had the virus in the first place. This is number 1. Number 2, in the United States, like in other countries, developed countries, for the longest time, once the virus was discovered and once the virus was known to be so infectious, people who believed had the virus were dissuaded, if you remember, to seek medical treatment. In other words, to go to the hospital, to the emergency rooms, because the emergency rooms were overflowing with people who had the virus already, and there were no emergency unit beds to accommodate the overflow of people. So basically, if you believed you suspected to have the virus, you could call your doctor, if you had one, who would tell you basically, if you don't have 99 fever, extreme fever, and you don't feel like you're dying, stay home and take care of yourself without giving you any type of medication and drugs, because nobody knew how to take care of the virus. But basically what you are told all this time is to stay, isolate yourself, and to stay in quarantine, not go out, and try to stay away from people. Definitely not go and see a doctor, because the doctors themselves were trying to protect themselves against the virus, and they are overworked with the number of patients who had the virus confirmed. So it's very difficult to tell to what extent the healthcare system in the US has contributed to spreading the virus here. It did, but to what extent, and was it more serious than in Europe? I don't believe so, because the European first reaction, initial reaction to the virus was the same, to advise people to stay in their homes and not to seek medical treatment unless it was an emergency. But by the time you felt it was an emergency, sometimes it was too late. And sometimes, even then, the doctors and the hospitals could not deal with the overflow of people going there. So we don't believe that it was specific to the US, the first reaction, the initial reaction to the virus was particular to the US. Now, the loss of insurance coverage among those losing employment. I honestly do not know if people having lost employment lost their insurance coverage as well. I don't know. I believe that their insurance would be covered by their employment place for as long as the confinement is in place. And only when the confinement is lifted, I believe, so the deconfinement starts and people are encouraged to go back to work, only in the cases where the employees refuse to go back to work for whatever reason, for fear of catching the virus. Only then the employer can get rid of them and cut their insurance coverage that goes with it. But for the time being, I think that temporarily anyway, people having lost their employment can still get their health benefits. That's my feeling. I don't know for a fact, but that's what I believe. And three, the massive costs required for containment, mitigation, treatment, which may not be covered by our insurance programs, and again, requiring government intervention. Again, this is not specific either to the United States. It's the same issue that all governments all over the place run into. The massive costs, obviously, of the confinement and its impact on the economy, obviously, with, well, you might have seen the unemployment rate is at 14.5%, which is unprecedented. It has to go back, you have to go back to the Great Depression in 1920s to reach those numbers, and apparently it's going to go up even, some people say up to 20%. So, but that's true for other countries as well. Now, as you might have seen also, the process of deconfining varies from, in the United States, it varies from state to state. In Europe, it varies from country to country because Europe has one, I mean, every country in Europe has one government, again, except with the exception of Germany, where also the Landers, the state government, decide when to lift the confinement in those areas. And probably all this would, it all depends how much longer this is going to go on. It all depends that once most of these confinement measures are lifted, we might experience a second wave of the virus with a high number of people contaminated, in which case we might go back to confinement once again. Nobody knows. At this point, some deconfinement measures have been taken very gingerly and very reluctantly by many. It remains to be seen what the consequences of these measures will be. But we won't have anything for sure before a couple of weeks, because it takes the incubation period is about a couple of weeks. So if by any chance you getting the virus tomorrow going to work, it won't show before 2 weeks, the end of May or early June. So it remains to be seen if by that time we're going again to have an increase in the number of cases, in which case, God knows, we might go back to confinement again. I have no, unfortunately, and nobody does, has an answer to that. Edward, why do you utilize the wonderful, positive, patriotic American exceptionalism in this very negative, insulting manner? If you love the USA so much, why don't you just leave? Well, I don't know how to answer your, first of all, I don't hate the United States, and I don't think that in my presentations I gave you any reason to believe so. And American exceptionalism, I don't use it in a negative way. I'm just saying that, and even less in an insulting manner. What I'm saying basically, Edward, is that exceptionalism is something that an exception to the rule. Now, exceptionalism can be understood as positive, exceptionalism can be understood as negative. Generally speaking, I agree with you, it's understood in a very positive way. That being said, in certain instances, exceptionalism is something that's different from the rest. That's the first definition of being an exception or exceptionalism. but I do not believe having used this term in a hateful or insulting manner. Alan,
Pierre?
yes.
That comment, I think, was directed to Tom, not to you.
Oh, I'm sorry. Yes, it wasn't directed to me. I apologize, Edward. I apologize. I saw your name. I saw your name, and then I read the question, but I didn't look indeed at Tom. That being said, Edward, I don't want to be a referee between you and Tom. Tom is old enough to defend himself. I don't believe that he uses American exceptionalism in a hateful and insulting manner either, but that's my opinion. All right, from Alan. Okay, so this article of April 19 is called, for those who are interested, we must end the cycle of neglect, panic, repeat, by Jensen Interlandi, about the decline of our public health system. Worth a read. Thank you, Alan, again. We must end the cycle of neglect, panic, repeat, by Jensen Interlandi. From Tom to everyone. You know, Edward, here comes the answer. Well, you see, to everybody, this was the main reason why for over 3 years, I avoided as much as I could domestic issues, and I stuck very closely to foreign relation issues. But again, I felt today that we are mature enough, all of us, to undertake an issue which is, I agree with you, very sensitive, but it's very topical at this time, which is a health insurance issue. And even that leads to these exchanges. So it only reinforced me in my conviction to be very careful in the future. Well, I'm not going to get into this, and so I want, that's between Tom and Edward. From Shelley. Hi, Shelley. Ça va? How has the great influx of refugees to Germany impacted the cost and payment for healthcare? Will the high mortality, that's number one, will the high mortality rate in elder care facilities due to the virus mandate a revolution in healthcare facilities for the elderly, and the payment for I don't know what you I don't know what you meant, this word, and the payment for healthcare. Okay, healthcare by insurance or the government. Okay. I don't know how the influx of refugees to Germany has impacted the cost of payment for healthcare, to be honest with you. And I don't know either the number of people among the refugees. Probably the Germans are keeping very close statistics on that issue, like on everything. But how the influx of refugees has impacted the cost and payment for healthcare? Was there a large number of people who came from back in 2015, 2016, from Syria in particular and Afghanistan? Was their number very high in terms of people who got the virus. I would assume that, to answer your question indirectly, I assume that the people who were officially accepted to Germany 5 years ago and 6 years ago and 4 years ago have received, are insured, knowing the German system, are insured by the state. Actually, it's mandatory insurance. Now, how many of them have no jobs and received health care following this virus? So in other words, they had an impact on the budget, on the healthcare budget in Germany. I cannot tell you because obviously they were distributed through different landers, through different states in Germany. So I don't have a percentage, and I don't know either how many of them contacted the virus. I don't know. I just don't have answer to that. If their number is higher than the percentage of the general population. Number two, will the high mortality rate in older care facilities mandate a revolution in healthcare facilities for the elderly? That's another question that will be debated, considering the number of people who died in these healthcare facilities, which, to be fair to those facilities, were not equipped, at least at the very beginning, to deal with the virus. So people who stayed there obviously were older and probably in worse shape than the general population, obviously, because they had to be taken care of on a permanent basis. So the percentage of people who died in those facilities were obviously higher than in the general population. Does that mandate a revolution? That's another question. A revolution, that's a very strong word. Should these healthcare facilities in the future have some kind of equipment dealing with epidemics and this type of emergencies that they could not foresee up to now? Probably, but then again, that will be a debate to be held once we get over the pandemic. And the payment for healthcare by insurance or the government. Well, that's part of the general population, so it all depends, Shelley, on the type of healthcare system that will be put into place in the US once the outbreak is over. All right, so there are many questions. This was the last one. So thank you very much. Well, that was a long session also. You take advantage of the fact that there are no limits on how long we on how long we can sit around and talk, unlike the council chambers where they throw us out at 12:30. But it's all good. I'm glad we had this conversation, and next week I'll try and go back to something less less controversial maybe, and And I don't know yet what we'll look at, because again, I have a limited number of subjects at this time because the virus is everywhere. So it impacts every aspect of foreign relation, foreign policy. Just one more thing for those who follow still what's going on elsewhere. Just to let you know, a subject that you haven't heard enough of. The Brexit negotiation started officially again. As you know, as a reminder, and Michelle, I don't want to hold you up for much longer. I'll be around for another couple of minutes that we're done. Just as a reminder, 31st of December, but again, nothing is in stone because now we don't know anymore with everything that's been happening. But officially, 31st of December of this year would be actually the Brexit will take place. For the time being, we have this transitional period during which everything is business as usual. In other words, the British access the single market of the European Union, and there are no changes from the European Union to England. Now, that being said, Johnson's government, Johnson was gone, as you know, also for a couple of weeks because he got the virus. He just came back last week and he repeated that as far as he's concerned, the UK will get out of Brexit no matter what by December 31st, which is, needless to say, leaves only, what, 7 months, 7.5 months for these complex, overly complicated negotiations to take place, and not only to take place, but for the two parties to come to some kind of agreement as to how to continue down the road. So today was the first meeting scheduled between the two parties, but obviously instead of meeting face to face, they met by, like us, by Zoom on each side of the channel, which is not very conducive to holding such complicated negotiations when you cannot sit down with your counterpart and over a cup of coffee and have informal discussion rather than formal discussion on Zoom when everything is recorded and the positions remain stiff. So we don't know where we're going with this Brexit issue, but obviously the positions are, once again, this morning they had the meeting and the position are still remain very far apart. For the British, they insist that after December 31st, the UK stay and have access, unlimited access to the EU single market. The Europeans are saying that's out of the question unless the UK is making such concessions to make it worse for the European Union. As I mentioned to you earlier, the main subject, main concern for the Europeans is the fishery rights. The British and fishery rights on one side, and also a commitment from the British not to change their environmental laws, the labor laws, which would make their products less expensive. Therefore, they would outcompete the Europeans when it comes to exporting products, so that the UK would become a very tough competitor for the European Union. And the UK is saying that's out of the question. As soon as 31st of December comes, the main reason why we want to get out of the European Union is to be able to set our own rules and procedures. So we'll definitely change our environmental standards, our labor rules, so that products in the UK will be competing with the European Union products, probably will be cheaper. So this is where we stand today. I just wanted to mention you not to forget Brexit altogether, because it will come up again in the near future. All right, that being said, let's wrap it up. Thank you all, and hope to see you all next week, safe, in good health, and well, till next Monday then. Thank you.
Have a great week, everybody. Thank you, Pierre.
Thank you. Bye.